Here we have a 42-year-old woman, Julie. Julie has an appointment. She complains of shortness of breath on exertion. She smokes and has occasional wheezes. What could be her diagnosis? Looking at her clinical records, the doctor notices previous visits for acute bronchitis, and they were treated very often with antibiotics. When specifically asked, Julie mentions frequent previous visits for acute bronchitis since she was 6 years old, worse since she started smoking at age 22. She presently smokes half a pack a day for 20 years, and she also grew up in a family of smokers, which means she has been exposed to smoke for a long period of her life. Julie has been worsening the last 3 months. She complains of shortness of breath when walking upstairs. She has wheezing at night and productive cough, and worse in the morning. Julie also noticed it in the colder weather. Also, we can do the 30-second COPD test, and that we can ask the patient and ask ourselves about this, and the patient can help us to diagnose. Do you smoke currently, or have you smoked cigarettes in the past? Do you cough regularly, which has certain characteristics we'll talk about later? And in asthma, the most important key point is that the obstruction is reversible, except that in latest stages of asthma, it might not be. So it can also be confused with COPD in later stages in severe asthma. So here we look at Julie's parametry results. This is the flow volume curve, and you have the characteristic notch that you see when there is obstruction. What is the characteristic of this curve here is that the curve before bronchodilator and after bronchodilator are almost similar. So it means there wasn't the test didn't show any reversibility. And now we can look at some Julie's spirometry results. We can see that the predicted FVC was 4.37 liters. The measured was 4.65. So we had 106% of the predicted. The FEV1 was lower than 80%, 79%. And when you look at the right side of the slide, there was only 70% increase after the bronchodilator. And the ratio was also under 70%, and after the bronchodilator, it was still under 70%. So, Alan, we'd like to show the diagnostic flow diagram for obstruction.
Yeah, so build the slide, please, James. So this is a diagnostic algorithm we've created for spirometry. And Jamie has just gone through this with you in the case before, but if you sort of review that, the first step we look at is looking at the ratio. And if the ratio is low, then you have obstructive airway disease. So when you look at that, the next step after that is going to be, is the FVC low? And then you're looking to see whether or not there's restriction. The funny thing about FVC is it's normal above 80% rather than 100%. So if the FVC is less than 80%, then there is a degree of restriction. So if there is both obstruction, the ratio is low, and restriction, the FVC is low, then you have a combined deficit of obstruction and restriction. At this point, it can be quite complicated. So very simply, you give a bit of a SAB and a bronchodilator, and you see if it reverses or not. And if it does reverse, then you have a likely diagnosis of having an obstructive airway disease like asthma. And if it doesn't reverse, then you need to investigate further why this person has restrictive airway disease, and you need things like full pulmonary function tests and CT scans, etc. So restrictive airway disease is not really what we're talking about here today. Many things cause restriction. If you have a chest wall problem, a neuromuscular problem can cause that, but airway obstruction is what we're talking about here. So if the ratio is low, less than 70%, the FVC is normal, then you have pure obstruction. If you have pure obstruction, then the question is, does it reverse or not? If it reverses, then you're considering asthma. If it doesn't reverse, you're considering COPD. And I say considering because, of course, as James already said, if you have very fixed obstruction from bad asthma, it may not reverse anymore. And we know that some patients with COPD will have some degree of reversibility. So it's all going to be a matter of how much reversibility and how much obstruction in a clinical setting that's going to help you decide the situation. So going back to Julie's spirometry that we saw earlier, her ratio was 64%, her FVC was normal, and therefore, with a lack of reversibility, her COPD looks like her spirometry looks like it's got COPD.
So these are the key points for Julie. If
Yeah.
we consider that she might have COPD. So we know that smoking cessation can prevent further long-term lung damage or slow the rate of decline of lung function. And also that if one bronchodilator fails, we have to ensure patient is compliant and able to use prescribed delivery system properly. And we also need to have to use stepwise approach to the treatment plan. And we have to do this in a circle. And this is a review, adjust, assess circle, and it's very similar to the one we have been doing for asthma for quite some time. And now it's also an approach that we are using for COPD. In every opportunity, in every encounter, we have to review and assess and adjust in a cycle so that we are sure that we are delivering the best care.
Julie had a childhood onset of symptoms, and she has lost a lot of lung function. And she gives this history of attacks of bronchitis, which is very common in histories that we get. So do you think the primary care physician should straight go to one bronchodilator, and if it fails, a second? Or wouldn't you consider a course of inhaled steroid trial, because in the hope of regaining lost lung function, considering she is young and we have not given her the opportunity to really improve?
If we look at this spirometry,
Yes.
it looks quite a lot as COPD. As the case progresses, we'll probably question that. Assuming it's COPD, obviously the initial start could be a bronchodilator. Except that we have this, as you mentioned, we have a quite clear childhood set of symptoms that have been occurring for repeatedly. And we should consider, could it be that she has had, since her childhood, she has had asthma that was not diagnosed, and when she started smoking, it got worse, and it became either COPD or a mix, a combination of asthma COPD.
Just to review back on Julie's spirometry, that she does not have restriction based on a normal FVC above 80%. Her FEV1 is 79%, so she has mild obstruction, and it does not reverse. So this appears to be a condition of COPD based on the spirometry. But if, and Jaime, to you,
what if these were Julie's spirometry results? Then we look at a complete different scenario, because here we see that the FEV1 increased from 2.98 liters to 3.50 liters. So that means an increase in 70.5% and over 200 milliliters. And so it might look that after all, and also the FEV1 FVC ratio increased from 64% to 75%. So after all, when you look at this, it looks like a different scenario. It doesn't look like COPD anymore, but it looks more like asthma. What do you think, Alan?
Well, very important what Jaime says. So this is a situation that shows that there actually is reversibility, and now her ratio is above 70%. So now you can categorically say that she does not have COPD. This makes all the difference in the world. Again, we've shown you two different situations of what the spirometry could look like. This is one where there is reversibility, the last time there wasn't. And obviously they're not both the same person, although just to make things difficult, you can actually have differences in different results in different days. And that's why most international guidelines recommend repeating spirometry in people with COPD before you label them, to make sure that in fact there's no reversibility over time.
Yes, let's look at the goals for effective management of asthma. And we have here a slide from GINA. GINA is a global initiative for asthma. And here they are: achieve and maintain control of the symptoms. We need also to prevent asthma exacerbations, maintain pulmonary function as close to normal levels as possible, so that the patient with asthma can maintain a normal activity level, including exercise. There's no excuse for an asthma patient not to exercise, because we can always control, or most of the times control, their asthma so that they can exercise. Actually, there's a lot of high-performance athletes who have asthma, and they have still achieved Olympic medals. We also have to avoid adverse effects from asthma medications, which means treating with the minimum efficient dose. So if we have gone up on the steps of asthma treatment, and we have able to manage and control symptoms, we have to try to go down and see if it still manages asthma properly, so that we keep the lower level of medicines that control the disease. We also have to prevent development of irreversible airflow limitation, and this is when we have severe asthma, this has to be treated in a different way by a multidisciplinary secondary and tertiary team, which can look at asthma and give appropriate medicines that are now available, and it's an opportunity for patients in many countries to have their asthma managed properly, not develop to an irreversible airflow. And we also have to prevent asthma mortality. In the developing countries, there's still a lot of asthma mortality. In the higher income countries, asthma mortality is residual, but still there is asthma deaths which are mostly avoidable. And this is one of key issue because very often it's people that navigate badly the system. They are jumping from doctor to doctor, doing doctor shopping and going from emergency service to different practitioners, and they get lost in the system, and they often do not do their medicines adequately, and we can prevent these deaths. If you look at the figure on the right side, you can here see both the 5 steps approach to asthma treatment from GINA, which I advise people to review, but also something that is new in GINA to 2020 is how to start treatment. And they advise exactly when to start when you look at the different sets of symptoms and severity of symptoms and frequency of symptoms, if you start on step 1, 2, 3, or 4. So this is a very good way to review our asthma treatment. It has been updated in between 2019 and 20. There's new recommendation for step 1. So at step 1, you should only use, should not use short-acting beta agonists alone. You should either combine them with an inhaled steroid or start with as-needed low-dose ICS formoterol. And this has changed quite dramatically what used to be done in the past recommendations for asthma treatment. And moving on, what if spirometry is not available? And this is something that has been subject of debate. As much as possible, we should have evidence that there is reversible obstruction if you want to diagnose asthma. But in some cases, it's not immediately available. And when we do a spirometry, the spirometry might be normal. So it's important to try to show some evidence that there was a reversible obstruction. And that can be done with peak flow meters that are done in practice. It can be aided by the use of validated questionnaires, and that some of these validated questionnaires can help you to diagnose asthma together with the peak flow meter. For the use of peak flow meter, there are different diagnostic criteria than there are for spirometry. I usually prefer to use this daily PEF variation over 10%. Nowadays, what is recommended by GINA is to have an excessive diurnal variability for 1-2 weeks, twice daily PEF monitoring. But it can also be done that once you have a suspicion of asthma, you record the FEV1 or the PEF, and with the peak flow meter you can only record the PEF, and after 4 weeks of inhaled steroids, you record again, and it shows that it has improved, and that can help you with diagnosis.
A lot of GPs don't keep a peak flow meter in their practice across the world, and even if they do, I have seen many of them don't use it. So is there any message that you can give, Jaime, on peak flow meter usage in clinical practice to many?
Sure, yes, sure. The peak flow meter is a very useful tool. As I've said before, if possible, it would be better to have immediately available spirometry.
Right.
If practitioners don't even have a peak flow meter, it's very unlikely that they will have immediate access to spirometry. So at least you should purchase a peak flow meter which is not that expensive, with disposable mouthpieces.
Yes.
And then you can do the pixelmeter immediately. So you have a patient coming into your practice with wheezing, shortness of breath, and you measure the pixelmeter, you give them a bronchodilator, a short-acting bronchodilator, and after 20 minutes you check again, and if this shows that there has been an improvement according to the standards I have just mentioned, then it is very likely that it is asthma. If the patient is not on an acute stage but is mentioning symptoms, and you measure the path in your practice, and you give them a course of inhaled steroids for 4 weeks, and you measure it again after 4 weeks, and it shows an improvement of 10%, then it is, I think it's 20%, sorry, it shows that probably it was asthma. It is very likely that it was asthma. So even in cases where you don't have spirometry available, a combination of standardized questionnaires and use of pixelmeters can be extremely helpful in making a record of probable asthma. And this probable asthma means a lot because you have a higher probability than if you just diagnose it on clinical criteria alone.
Yeah,
so I think it's advisable to use them.
Absolutely, I think it's so as well.
The pixelmeter and the spirometer, there is what they call the mini spirometer, which measure FEV1 and FEV6.
Yeah. And
the comparison between FEV1 and FEV6, FEV6 is a proxy to FVC. So by using that in clinic, which you don't require such an expensive and time-consuming test as a spirometer, you can have a better chance of diagnosis when you compare it with a good clinical tool.
Do you see more of those FEV6 devices being used in the future, Jai, in primary care?
Well, I think that nowadays the next stage is not the separate ones, but you use it on your cell phone.
Sure.
Yeah, now there's quite good devices that you just have a small piece that you attach to your phone, and with disposable mouthpieces. That's before COVID. Now with COVID we can do that. But you could use it with your small program in your phone, and you have that also available. But there is a use for that because it's quickly done in practice. Not so much, I would say, for diagnosis, but as I said, for excluding diagnosis. Sure. But eventually for follow-up and monitoring. That is more useful than for diagnosis.
Sure.
All this technology is coming, right? As technology is coming, things are getting smaller and less expensive and more available to all of us around the world. At the end of the day, we want to have a firm diagnosis, because with a firm diagnosis, we can decide our therapy appropriately. That's what it comes down to. And certain therapy is going to be across the board for both diseases. We're vaccinating, we're preventing smoking, we're exercising. That's important for everybody. But when we talk about pharmacotherapy, there's some pretty important pearls here and some basic differences that are going to be the difference. And the difference number one, of course, is that for asthma, we do not want to give just a bronchodilator. And we've talked about Gina saying now that inhaled steroids at every step, but also we've learned that long-acting beta agonists in asthma as monotherapy convey a risk of mortality. And that was something found in the salmeterol monotherapy asthma relief trial, where young people were given salmeterol when LABAs were first coming around without inhaled steroids, and about 20 young Afro-Americans died. So LABA monotherapy is bad for asthma. Similarly, inhaled steroids, as we talked about earlier, does not treat COPD. They don't treat mild COPD at all, and therefore there's no value in treating it. So isolated ICS shouldn't be used in COPD. That doesn't mean steroids shouldn't be used in COPD. In the appropriate patient for exacerbation reduction and so on, it can be quite important. So overall, we want to make sure our treatment matches the condition. And there's some overlap because we use both drugs for both conditions. But if we do this appropriately, then we're giving the right drug to the right person at the right time. And isn't that what we're trying to do for everybody?